So thank you, Tom, and I applaud what Finn is doing to help educate individuals about this disease, prostate cancer. So if you'll bear with me just a minute, I will see if I can get this presentation to come up here. Now, active surveillance, and when you think about it first, you might ask, why in the world would anyone not want to treat a deadly disease? But I'm going to make the argument this morning that this is a very underutilized approach, and we should be talking about it more. Everyone can see the slides, I assume? Yes. It's good. So I have no disclosures. I'm not going to talk about any patents or any things that Tom asked us not to do. But I want to emphasize that when a man gets diagnosed with prostate cancer, this is truly a management dilemma. And here is the reason. For the majority of men, there is absolutely no evidence of a greater benefit for one management option over another, and that includes no immediate treatment. Think about that for a minute, because most men are diagnosed after age 65, and a large proportion of those men have a disease for which randomized trials have shown no benefit. And that's what makes this such a hard decision for men. Active surveillance programs, as a result of what I just told you, have grown all across America and North America. But the fact is they're mostly in academic institutions, and a lot of men today never hear about active surveillance as a management option. So I'm going to address three separate areas. First, to try to talk for a minute about the concept and the rationale of active surveillance. Second, the selection of candidates, and finally, the outcomes that we know about today from active surveillance programs. So let's start with the concept and rationale. I'm sure everyone at this conference knows that today a diagnosis of prostate cancer starts and is initiated with a screening process. Most men today get a diagnosis through screening. And screening for prostate cancer results in a large proportion of men who are treated unnecessarily. Why? Because of overdiagnosis. Let me define overdiagnosis as the diagnosis of someone who otherwise would never have known that they had prostate cancer if they hadn't been screened in the first place. So you might ask, well, what proportion of men are overdiagnosed with screening? It's estimated to be about 1 in 4 overall. But for those men over age 70, it's about 50 to 70%. So a lot of men diagnosed today are overdiagnosed with a disease they never would have known about. The reason this happens is because these non-lethal cancers are very, very prevalent. They're extremely easy to detect with a needle after a PSA suggests that there's a problem. And additionally, the rates of screening are very high. They're high in the elderly and those in poor health. And those are the very groups of individuals for which we have trials suggesting they're not going to benefit from treatment, yet we screen them at high rates. And finally, in our healthcare system, as I'm going to show you, virtually everyone who gets diagnosed today gets treated almost immediately. So how could we reduce the harms of prostate cancer screening? I think there are two ways. We could do a better job at targeted screening, that is, identifying the individuals who are most likely to benefit from screening, and focus our efforts in screening those particular individuals, something I'm not going to talk about today. Second, we could reduce overtreatment by simply educating men that for some men, treatment is not necessary. We don't need to treat every cancer, and that's what we call active surveillance. Active surveillance isn't watchful waiting, though, and I want to make a distinction. You can see in this cartoon, the patient says, I know we agreed to a period of watchful waiting, but this is more watchful waiting than I bargained for. So let's make a distinction between watchful waiting and active surveillance. Watchful waiting was a term that was popular in the era before PSA screening. Remember, most men in that era had disease that was advanced and often couldn't be cured. Also, the treatments at that time were quite morbid. So the physician and the patient wanted to do everything they could to avoid treatments. And these were men that often had a limited life expectancy, had more advanced disease, So the idea was to delay treatment until the disease was advanced, at which point palliative treatment would be initiated, usually with hormonal therapy. However, as opposed to watchful waiting, active surveillance is a very, very different concept. Here, we're talking about individualizing management. That is, taking individuals who are fit for radical treatment. They have localized disease. We think often they don't need to be treated immediately, and the idea would be to monitor these people very carefully and then intervene at an early period should the disease progress, and intervene at a time when the disease is still curable. Now, there are two randomized trials. I want to pause for a minute and just make sure that everyone in the room understands that a randomized trial is the type of data that the FDA requires to approve a drug in this country. So if you wanted to approve a drug, you'd have to have a group that got the drug and a group that didn't get the drug. Here we're talking about exactly the same trial, a trial that compared an intervention called radical prostatectomy to a non-intervention called observation. And these two trials are very important, and I'll explain why. The first trial was in Scandinavia, and it occurred in an era before PSA screening was prevalent. So these were not the men diagnosed today. These were men who had disease 5 to 10 years more advanced than what we're diagnosing today. Yet, surgery resulted in no reduction in metastatic disease or prostate cancer death, no reduction in prostate cancer death among men over age 65 years. And that was over a 15-year period. So men over age 65 didn't benefit. So who did benefit? Men under age 65. 7 men under age 65 would need to undergo surgery to prevent 1 prostate cancer death. So 6 out of 7 did not benefit over a 15-year period. The second trial, the pivot trial, occurred in the PSA era with 10-year follow-up, and surgery did reduce prostate cancer death, but the group of individuals who benefited were those men who had PSAs over 10 and those with high-grade cancers. So the take-home message is here, if you're a younger man, an older man over age 65, and you don't have a high-grade cancer and you have a PSA over 10, you probably should not be asking, which treatment would be best for me? You should probably be asking, do I need treatment at all as a first step? Now, this would be a slam dunk. Treatment would be a slam dunk. We can detect it. It's been labeled as a cancer. Why not treat it? And that would be the conclusion virtually everyone would come to, except there are harms associated with every treatment we have. Now, this is the best data that I can summarize for you that shows the benefits and harms for 100 men in this country who get diagnosed with prostate cancer. So all of them are diagnosed, and we're going to look at the outcome over 15 to 20 years. The colored light green color represents that 90 of them will be treated, because 90% of men who get diagnosed get treated in this country. The orange bars, colored bars, represent that out of those 100, 40, if they get treated, are going to have some bother from urinary, sexual, or bowel problems. I'm not saying how extensive they are, but they will have some bother from that. And then finally, the benefit, perhaps 11 to 12 individuals will have prostate cancer death prevented or prevention of metastatic disease. So again, treatment of prostate cancer is not a slam dunk. One has to consider the harms that are associated with treatment. And for that reason, the American Urologic Association, the European Urologic Association, the National Comprehensive Cancer Network, all include active surveillance as an option for management of localized prostate cancer. But there is a great deal of uncertainty surrounding surveillance in terms of how do we select candidates, who are the best candidates, when we select them, how do we monitor them, what are the triggers that should say you need to be treated at this point, and what are the long-term outcomes. So for the next couple of minutes, I'm going to talk to you about selecting individuals for active surveillance. Now, two considerations in talking to patients about surveillance. One needs to consider not just the patient, but also the tumor. The tumor is important. In other words, does the particular tumor this person's been diagnosed with put them at risk of death from prostate cancer? And we generally use grade, PSA, and the stage of the cancer to make those determinations. There are a lot of exciting things going on in the area of imaging, such as MRI, and I think yesterday you may have talked about gene signatures or gene panels. I think these are exciting developments, but at this point I don't think we know exactly how to use them to select patients for surveillance, so I'm not going to talk about those. We also have to take the patient into consideration, because those who have a shorter life expectancy are less likely to benefit from being treated. So we have to take age and overall health into consideration. And for a disease where physicians don't know the answer, in every case, patient preferences have to play a large part of the decision. So let me talk about grade for a minute so we're all on the same page. The Gleason grading system is what we use to grade cancers. It's a very important part of our assessment. And the pathologist then looks under the microscope and assigns a grade on a scale of 1 to 5, which I'll show you has been modified. 5 being the most aggressive looking cancer, 1 being the least most aggressive. And since cancers are made up of multiple grades, the pathologist actually assigns the first most prevalent pattern and the second most prevalent pattern and adds the two together to come up with a score. In reality, the pathologists no longer grade or assign grades of 1 and 2. So today, they are grades of 3, 4, or 5. And if you were going to add those grades together, you would come up with scores of between 6 and 10. It turns out that a lot of experts in this country believe that Gleason 6 cancer should not even be called cancer, because it, in most cases, behaves in a very indolent way. Our approach at Johns Hopkins, instead of calling Gleason 6 no cancer or not cancer, our approach has been to use a classification system that gives patients the idea that when they get diagnosed with a Gleason 6 cancer, they're at the least aggressive end of the scale. There are 1 out of 5. If they have a higher grade cancer, for example, 8, then there are 4 out of 5. So we emphasize to patients with Gleason 6 disease, what you see in the very bottom of that slide, you're a 1 out of 5, and your risk of death as a result of prostate cancer is similar whether you get this treated or not over a 10 to 15 year period, as long as you have low stage disease and as long as you have a PSA less than 10. And I think that at least helps patients understand that they're in this very low risk category for which we think surveillance is appropriate. I mentioned stages, which are also important. Stage is assigned based on the digital rectal examination, what can or cannot be felt on rectal exam. And the 2 stages that I circled there, T1, meaning nothing can be felt on rectal exam. You see the picture of the prostate with the cancer in the middle. And T2A, which means minimally palpable disease on rectal exam, we also feel are appropriate for surveillance. Whereas stages that reflect more extensive disease or disease beyond the prostate, we believe, and most experts believe, they would not be appropriate candidates for active surveillance. So to summarize the individuals that we think are prime candidates or best candidates for surveillance, we use 2 risk classification schemes. The first one was popularized by Anthony D'Amico, a radiation oncologist, and in this classification scheme, he uses stage T1C, T2A, which I just told you about, PSA less than 10. Remember, we saw in a randomized trial that it was the men with PSA over 10 that benefit. Men with PSA less than 10 less likely to benefit from treatment. And those with a Gleason score 6 cancer, which I told you some experts believe shouldn't even be called cancer. The second classification system was one that was popularized by John Epstein at Johns Hopkins. And that includes men who have disease that can't be felt on rectal exam, stage T1C, a PSA density less than 0.15. That just simply means the PSA is less than 15% of the size of the prostate, a very strong predictor of whether or not aggressive disease is present. Again, a Gleason 6 cancer, less than 3 cores with any cancer, and no more than 50% involvement of any core with cancer. And it turned out that those criteria, the Epstein criteria, were very predictive of the absence of aggressive disease. So together one could think about men with this disease or these criteria as having favorable risk disease. The National Comprehensive Cancer Network is a group of cancer centers throughout the U.S., and they put together guidelines for management of all types of cancer, breast, pancreas, colon, and their recommendations for prostate cancer is that for those with very low risk disease that meet the Epstein criteria, who have less than a 20-year life expectancy, active surveillance is actually the preferred option. Not treatment, but active surveillance. For those men in that low-risk category that fell into the D'Amico classification scheme, for those with more than a 10-year life expectancy, all of the options, surveillance, radiation, radical prostatectomy, would be considered reasonable options. But the opposite side of the coin, if they had less than a 10-year life expectancy, surveillance would be the preferred management option. So I told you that the tumor is not the only important factor here. The patient is also an important factor, and one needs to consider both the patient's overall health state and their age in making a decision about whether surveillance is right for them. So in this study, which is called a decision analysis, what we're looking at here is whether surgery or surveillance would be the preferred option based on how many additional years of life were left after the treatment. But it's not just years of life, it's quality adjusted life. So it takes into account the quality of that life. And so what one can see on the axis where you see poor to excellent health is from the bottom, poor health, at the top, excellent health. And on the other axis, the horizontal axis, you can see age from 50 to 75. So look at the little check there. The cross shows a 65-year-old man who's in average health. And for that individual, active surveillance would be preferred. But if you took that X and moved it up to the top of the slide, where that 65-year-old is now in excellent health, surgery may be the preferred option. On the other hand, if you go down to the lower age groups, say 50 to 55, for the person in very poor health, even if he's young, surveillance may be the preferred option. And you can also go over to the far side of the graph, men who are in their 70s, virtually nobody in their 70s who has favorable risk disease should, in my opinion, be considering treatment of prostate cancer, because these are the men that almost certainly are not going to benefit from treatment. Now, there's one caveat to this study. All of these results were very, very easily moved or changed by a patient's personal preferences, which are very important in determining the outcomes I just showed you. So the ideal candidate for surveillance, in my opinion, is the older man with a 10 to 20-year life expectancy or less. He has very low to low risk disease. I just gave you the criteria for that. And also the person's personal preference is to avoid the side effects of treatment. And it's usually a person who values the present more than the future. In other words, a person who is very interested in his quality of life. So let me talk for just a moment about some of the outcomes in active surveillance, and I'll summarize these for you in active surveillance programs in North America. The most common trigger, if a man is in surveillance, the most common trigger for intervention is the PSA is going up, or on a follow-up biopsy, he has higher grade disease. It's no longer Gleason 6 disease, and it appears more aggressive. About 25 to 50% of men are going to end up being treated in 5 to 10 years. About 1 in 4 of those get treated not because something was found on a biopsy that was scary or looked more aggressive, but because they became uncomfortable with surveillance in the first place and left to be treated. A third, 30 to 40%, we find a higher grade cancer, and that triggers the intervention. and about 30 to 40% the PSA goes up, and that triggers the intervention. Most grade reclassification, what I mean by that is when we find a higher grade cancer in our surveillance program, the vast majority of it occurs in the first couple of years. Why? Because the biopsy is usually missing the high grade cancer, and follow-up biopsies eventually find it. Not because we don't think it's because the Gleason 6 changed into a higher grade cancer over a longer period of time, but rather because we missed it in the first place. And last, the cancer-specific survival, meaning death from prostate cancer, is extremely unlikely over 10 years. In other words, far less than 5% of men who are monitored over a 10-year period in surveillance are going to die of prostate cancer. So now a little bit about the Johns Hopkins program. You can see since 1995, the cumulative recruitment of men into our surveillance program has grown dramatically, and now we have around 1,200 men in the program. And recruitment has been a little more rapid in the last years as opposed to the early years of the program. The average age, which you can see on that graph, is about 67. That's a frequency plot that just simply shows you the number of men by age who had this very low risk category versus the low risk category. And it turns out that about 80% are very low risk and about 20% low risk. 89% are Caucasians, 7% African Americans, and 4% others. So we are underrepresented in terms of minorities. We follow men at Johns Hopkins with twice yearly digital rectal exam and a PSA test, and an annual prostate biopsy to assess their disease. And then again, our trigger for intervention, for telling a man he needs to be treated, is finding a more aggressive cancer on a prostate biopsy and not a rise in PSA. Now, I want you just to look at the very last column of this slide where it says rate per 100 person years, because what that actually is percent per year. And it shows you the outcomes in percent per year. So if you look, exit from program, about 13% of men per year are leaving the Johns Hopkins surveillance program. Why are they leaving? You can see right underneath that, 10% per year are leaving to undergo curative intervention. And under that, you see about 9% are being reclassified. We find something on a biopsy for which we say you need to be treated. So the difference between that 9.7 and 8.9, or rather 10% and 9%, are the proportion of people who undergo curative intervention even though they don't have an absolute indication for it. Going down further, you see 4% of men per year get upgraded. In other words, they have a higher grade disease, higher than Gleason 6, and that would also trigger intervention. And then death from another cause, non-prostate cancer, 0.5% per year. And since this slide was made, there's been one death from prostate cancer in this program, which means one death in about 1,200 individuals who've been in the program. Now, having done this for 25 years or maybe a little more, I can tell you what patients want to know. What do I have to lose if I am not treated immediately? That's what patients want to know. So a group of collaborators from Johns Hopkins, from the National Cancer Institute, and from UCSF put data together to try to address this question, and this is modeling data because it's the only way you can answer that question right now. So what the investigators did is they looked at the time to treatment in the Johns Hopkins surveillance program, and then, assuming that some of the men in the program would get treated, they looked at, if they were treated, what would be the time to PSA recurrence, if it occurred, and if PSA recurrence happened and they underwent treatment, what would be the time to prostate cancer death? So all of those parts of the model are very well known. And then the investigators asked, so what would happen to men in a surveillance program versus men who underwent surgery immediately? And you can see on the slide, the model projected that 2.8% of men on surveillance and 1.6% of men who underwent immediate surgery would die of their disease in 20 years. If you looked over a lifetime, it was 3.4% for surveillance and 2% for immediate surgery. Now, that translates into an average projected increase in life expectancy associated with immediate surgery of 1.8 months. In other words, the advantage for a person undergoing surgery immediately versus surveillance was an additional 1.8 months of life. The benefit on surveillance would be that that person on average would remain free of treatment for an additional 6.4 years. So the conclusion of the study is at the bottom of the slide. Active surveillance is likely to produce a very modest decline in prostate cancer survival among men diagnosed with the favorable risk disease we talked about, but it could lead to significant benefits in terms of quality of life. So, how many men in the United States would qualify for surveillance? That's what this slide shows you. Pay attention only to the light part of the bars, which are men with favorable or low-risk disease. That's the proportion of men who at diagnosis have disease for which surveillance might be appropriate. And then just look at the men beyond age 61 and above 80. So that represents about 30 to 40% of older men, not just who I think would be appropriate for surveillance, but who randomized trials have shown these people would be appropriate for surveillance and probably should not be treated. Now let's look at the disconnect, what's actually going on in the United States. And that was my whole point for making my original statement that surveillance is underutilized. You're looking at the bars represent the proportion of men who get treated and the proportion of men who don't get treated by age after they get diagnosed with favorable risk disease. So you're only looking at the group of men for whom surveillance would be most appropriate. And notice that in the older age group, only 12% of men aged 65 to 74 are not being treated. And this is the astounding fact, I think. 80% of men, only 21% are not being treated. 80% of men over age 75, despite the fact that randomized trials tell us these men should not be treated, 80% of them are being treated. So let me summarize. Overtreatment of prostate cancer is a very serious problem in this country, and it is precipitated by screening for prostate cancer. We all know that screening is beneficial, but this is one of the bad parts of screening. The ratio of benefit to harm with prostate cancer screening, I believe, could be improved dramatically with wider acceptance of active surveillance for the carefully selected men. And that's exactly what we've been trying to do at Johns Hopkins, is identify those men for whom surveillance would be safest. So thank you very much for your attention.
Thank you, Dr. Carter, for that great presentation. I think we all now have a much better understanding of active surveillance. And I know there are lots of questions in the audience, but I would ask that you hold those questions and listen to the presentations, and we'll bring all the speakers back up and for question and answer period. The next presenter is Dr. Edward Schaeffer. And Dr. Schaeffer is also at Johns Hopkins, where he's Associate Professor of Urology, Oncology, and Pathology. And he's a co-director of the Prostate Cancer Multidisciplinary Clinic. And Dr. Schaeffer has spent some time, and I know Dr. Schaeffer and Dr. Carter work together, by the way. But he's completed a study about active surveillance in African Americans. And there have been some very interesting findings that emanated from the study. So we're anxious to learn what those findings are. So now I welcome Dr. Edward Schaeffer.
Well, I'd like to thank Mr. Farrington for inviting me to come down here today. And the purpose of this talk is to really build on what Dr. Carter just spoke with you about and explore more special considerations that African American men may want to have when they're considering active surveillance. Now, as Bal just emphasized, there's been a tremendously increased emphasis on active surveillance for men with very low risk prostate cancer. And here's a table from a recent review that in effect summarizes that the outcomes for most men who choose active surveillance are really exceptional. And so, again, the take-home message of Dr. Carter's talk was that in well-selected men, active surveillance is a very good option. Now, the next question that we wanted to answer was, how do African American men do in active surveillance? As we just heard, most large active surveillance cohorts contain very few African American men. Hopkins has about 7%. The other large cohorts, Toronto, San Francisco, all contain few African American men. And the question was, do African American men who are considering active surveillance need special consideration? And so I know that you've heard about this in years past at this conference, and certainly on all of our minds, but African Americans have worse prostate cancer outcomes than do Caucasians. And here's some statistics from the American Cancer Society which really illustrate this significant discrepancy in outcomes. African Americans are about twice as likely to be diagnosed with prostate cancer, and more importantly, they're about twice as likely to be diagnosed with metastatic prostate cancer and die from it. So this is a serious problem, and the disease has a different biology in African Americans. And I know that you've heard from Isaac Powell in the past, and he's very nicely shown that in African Americans, he postulates that there's probably a faster cancer growth over time. And Dr. Mall and Dr. McLeod, who have also demonstrated that at the time of diagnosis, African Americans have higher PSA values. In some, prostate cancers in African American men are more aggressive, and I certainly think are biologically distinct. Now, what do we know about African American men in active surveillance cohorts? There's been 3 good studies that have really kind of acted to spur our further exploration of this concept. So the University of Pennsylvania looked at about 50 men, and these were African American men who had criteria that Dr. Carter talked about. These were men who had very low risk cancer, and they had surgery right away. And what they showed, this is in this left panel, was that there was no difference at the time of surgery when compared to Caucasian men in terms of how much cancer they had and how aggressive it was. Contrast that with this Miami and Duke studies. These were observations made from their actual active surveillance groups, and what they showed was that if you were African American, you had a much higher likelihood, and that's just this HR or hazard ratio, much higher likelihood of having progression of your symptoms of your disease in active surveillance. Now, what are the limitations of these studies? These are very provocative. One, of course, is that they had very small numbers. Okay, these are 50 men, 25 men. And the other thing is that they didn't include something that Dr. Carter de-emphasized, but really he brought to the forefront, and that is that PSA density is one of the most important predictors for how a patient would do in active surveillance. And PSA density was not part of these studies. And that is part of the National Comprehensive Cancer Network's criteria for men to consider active surveillance. So these studies were clearly very thought-provoking for us, and so our research team, which includes Dr. Carter, really began to explore this. And so in our mind, the paradox was as follows. African Americans have more aggressive disease, they have faster growing cancers, and overall have worse outcomes. Yet we offer active surveillance to all men with low-grade, low-stage tumors. Are there disparities in outcomes for African Americans with low-risk prostate cancer? Do we need to have special criteria for them? And we sought to answer this with 3 main questions. And the first way that we looked at this was to look at African American men with very low-risk prostate cancer who underwent immediate treatment, similar to this Penn study I told you about, and we compared their outcomes to Caucasian men. And the difference was that we didn't look at 50 men, we looked at 1,700 plus men who we treated at Johns Hopkins. And this included over 250 African American men. And the measures that we looked at were simple. We looked at the grade of the cancer at surgery. So these were men who came in and on paper they had very minimally aggressive cancers. And we looked after surgery, how aggressive was the cancer, how extensive was the cancer, and then we used a metric for their overall curability. And here's a very complicated table that summarizes some of our findings. And what I'm going to do for you is just highlight the points we just talked about. So if you look at the grade of the cancer, these are all men that came in with this low-grade cancer, Gleason 6. And we looked at how often that grade changed and got to a more aggressive number. And it went up significantly. The extent of the tumor was also much more. And our metric for curability, which is a complicated algorithm that shows how curable their disease was at the time of surgery, was much higher in African Americans compared to Caucasians. Here's another table that summarizes the results. So this, again, what was the likelihood of having non-organ confined disease? This is the cancer pushing outside of the capsule of the prostate. It was twice as high in African Americans, which are the gold bar. The likelihood of having your grade of your cancer change was also much higher. The likelihood that cancer was left behind at surgery was higher. And this CAPRA S3 notion is a metric for curability. And so, on average, African American men had more aggressive features and were less likely to be cured when they had their treatment. So what you can do is you can take all these factors and you can put them into a complex algorithm, and you can do multivariable logaritmic regression. And what you can do is you can see whether or not African American race was associated with poor outcomes. And what we found was that this in fact was the case, and African American men are about 3.5-fold more likely to have adverse pathology. This is more extensive cancer, and they're about 2.5 times more likely to have a higher grade or more aggressive cancer in this particular study. And so, in summary, African Americans with very low risk prostate cancer had poorer prostate cancer specific outcomes. They had more upgrading and more upstaging, and we believe that the current low-risk stratification system was missing significant cancers in these men. And so we concluded that African Americans with very low-risk cancer are at higher risk and certainly should be at least consulted as such. Now this prompted our second question, and that was the exciting part. What was the basis for this disparity in outcomes with very low-risk cancer? Was this a biologic phenomenon? Was there something about the cancers? Were they growing faster? Or was this simply an anatomic phenomenon? Did we just miss the cancers on the biopsy? And so to explore this question, we utilized one of our tremendous resources at Johns Hopkins, which is Dr. Jonathan Epstein. And he is really the world's premier prostate cancer pathologist. He looks at all the tissues under the microscope, and we asked him to look at these cases I just described to you. And so what we did was we again took the same cases I just told you about. These are men who had surgery, and we looked at their prostates under the microscope. And what we did was we looked for where the largest cancer was and where the highest grade cancer was. And we asked him to just chart it out. It's just a map, a template. And we looked at 100 cases of Caucasians and 100 cases of African Americans. And this is a picture of what Dr. Epstein looks at every day, a couple hundred times a day. This is a prostate that was removed from a man. And just for some orientation, at the bottom of the screen would be the rectum. So when men go to see their doctor, they often have a rectal exam. The reason that they do is because you can feel the prostate on the rectal exam. And the bottom half of the slide, you can see there's 4 sections. The bottom half of the slide is the area of the prostate closest to the rectum. This is where we traditionally think most prostate cancers occur. And it's an area where we can easily access the prostate with a biopsy. Now, right at the crosshatch in the middle would be the urethra, and that's the tube that men urinate through when they go to the bathroom. And then the area above that, the 2 upper boxes, is what we call the anterior part of the prostate. It's the farthest away from the rectum. So what Dr. Epstein did was looked at 100 cases. And so this is about 50 or 60 slides for each case. And he went through, and when a pathologist looks at a prostate specimen, what they do is they actually mark out, as you can see with these little dots, where they see the cancer. And here's a representative slide of a case from a Caucasian man. The tumor is very low in the prostate, right along the edge. And what was striking to us, and was really a remarkable finding, was that on average, African American men had many more tumors that were above the urethra in this anterior part of the prostate. And you can see this dotted out here with this very dramatic example. And so here's a summary of our findings. And so when looking at 100, just under 100 cases for Caucasians versus African Americans, the tumors were bigger. The tumors were higher grade. I just told you we knew that before. And remarkably, as I just illustrated with that actual specimen, the tumors were in different locations. So over 50% of the time in African American men who, when we originally saw them in clinic, we thought they had very minimal disease, actually had more aggressive disease. It was hiding from our view in this anterior portion of the prostate. And these little red bars would just be an example of what we would typically, how a biopsy needle would typically sample the prostate. So we would aim the biopsy needles, and they do a very good job sampling this posterior part of the prostate, close to the rectum. But it's much harder to actually sample these areas that are farther away from the rectum. And so we began to think that this may be why we are seeing this very interesting finding. Now, as Dr. Carter illustrated, men who have Gleason 6 prostate cancer do very well in active surveillance and are unlikely to die from their disease. Men who have higher grade cancers, Gleason 7 or higher, have a little bit riskier disease, and the discussion process with their physicians should be more detailed. And so what we did in our study was actually look to see what was the distribution of these higher grade tumors in Caucasians versus African American men. And what was really striking to us was that, in contrast to Caucasians, who, if they did have more aggressive disease, it was always in this posterior area, shown by this 90%. African Americans, about 60% of the time, had their most aggressive tumor far away from the urethra in an area that's harder to biopsy. So overall, African Americans had their biggest tumors about 50% of the time far away from the urethra. But if you just say, well, I'm interested only in the really aggressive tumors, well, they're even more pushed towards the top. So anatomic locations account for some of these missed cancers. Among men with very low risk cancer who underwent immediate surgery, they're more likely to have significant high-grade tumors in this anterior portion of the prostate. And so we believe that African American men considering surveillance may need a better staging strategy to rule out this occult high-grade cancer. This may mean we develop alternative biopsy strategies. This may mean that we utilize MRI imaging, as Dr. Carter alluded to, we do now in our program, to better see these tumors, which if they're big enough, you can see them on MRI. Now, the last question we asked, because the first two questions we asked were based on men who came to us, we thought they had low-risk cancer, and they had surgery right away. So we actually went back to our database of our active surveillance patients, and we actually said, how do men who are African American who are actually in our active surveillance database fare? How do they do? And so again, this was the same criteria outlined by Dr. Epstein, our pathologist. And we have 75 men in our cohort, and if you use the very strict criteria, there's just under 50 men who had very low-risk cancer that we followed over time in our active surveillance group. And we looked at progression, or as Dr. Carter called it, reclassification, either by grade, meaning the cancer becomes more aggressive when we follow patients over time, or by increased size of their tumor. And so overall, these fancy numbers basically suggest that African Americans in our active surveillance cohort are at increased risk for having progression of their disease. So is it progression by grade or volume? So we broke things down, and this is just an overall how people do. So the red bar is African Americans, and if you look over time, they fall out of the study more often. Now, if you look at progression by volume, the red bar and the blue bar, although they look a little different on the image, there's no difference, okay? So it does not appear as though African Americans have, at least for Gleason 6 cancer, more disease over time. The striking difference is that over time, African Americans in our active surveillance cohort are found to have more high-grade cancer, okay? And so the difference between Caucasians shown in the blue bar versus African Americans in the red bar is very different. And this may be because of it's not necessarily because they develop a higher grade cancer over time, but what we think it is that these tumors may be just hiding from us and are more difficult to sample. So, summary number 3, among men with very low risk prostate cancer who've been prospectively enrolled in our active surveillance program at Hopkins are at a higher risk of progression. And if the goal of active surveillance is to monitor men without high-grade disease, then we need race-specific selection criteria or alternative strategies to stage African American men with prostate cancer. So in conclusion, African American men with NCCN, very low risk cancer, experience significantly different oncologic outcomes. They have adverse pathology if they undergo immediate surgery. They have higher risk for upgrading on serial biopsies. And our detailed pathologic study provides some insight into why this is. They have higher grade cancers in locations that are more difficult to biopsy with their traditional approach. And so we think the development of novel imaging or biopsy strategies may be helpful in these cases. And so where are we going with this? Well, I think you've learned at this conference in years past that there are definitely biological differences in African American tumors. We also think now that there are anatomic differences, and clearly these two things come together and may account for some of the disparities that we've seen. And so I'd just like to acknowledge my research support and our research team, Dr. Carter, Ashley Ross, and Deb Sundy is actually a young urologist in training who did a large burden of all of this work for us today.
Dr. Schaeffer, thank you for this great insight on African American men and the active surveillance program.
The information that you now have available, when will it be available for primary care physicians and other healthcare professionals who are on the first line, they're the folks who actually start the anxiety journey when they're talking with their patients, because they don't fully understand. Obviously, they don't know what you know in your team. When is this available for continuing medical education units, which will provide an incentive for these doctors and others to take advantage of this new information? That's part of that's the primary question, because some of the anxiety that patients, and I was one, feel is that I'm trying to get a better understanding of how much time do I really have so I can make those decisions about quality of life. Absent anyone who really knows what they're talking about on these issues, then I will probably go in a direction that maybe I shouldn't, only because there's not very much to work with. And related to this, is there a study available which deals with the social, psychological factors that impact man's decision regarding what to do once he learns of his current situation?
Go ahead. Your light's on.
Dr. Schaeffer said my light was on. Okay, that was a trick. Well, that is an excellent question, and I think there are two parts to it. One was, how do we educate primary care physicians? And that's a big undertaking. At Hopkins, we are trying and attempting to do that through something called a clinical decision support tool, where we have built into an electronic medical record prompters that help primary care physicians determine whether screening is right for a particular person. Obviously, it's not right for everybody, and each individual has to bring to the table their own personal preferences. So that's what this clinical decision support tool helps do. I can't give you a date when every primary care physician would have access to that, but I think that will be the future, because I think primary care physicians and patients need to work together to determine those important issues. Now, you alluded to a primary care physician helping a patient make a decision about management. And I think that's a little more complex, because I don't think they have the information to do that. But on the other hand, they also know the patient much better than the specialist. So I think one approach that works well, I believe, is the patient, once a diagnosis is made, has developed a relationship with the urologist. Hopefully the urologist gives them the perspective, all the management options that are available, surveillance, other interventions, and then they go back to the primary care physician who knows them much better than the specialist and talk about, all right, what is the management option that feels right for you? That's the way I have worked with primary care physicians through our
All right, Dr. Schaeffer.
Thank you very much for an outstanding presentation. For African American men in active surveillance, until we have better imaging of the anterior prostate portion, what would you recommend about the active surveillance, not knowing what the anterior prostate
Yeah.
shows?
So again, we're not. I'm not advocating that active surveillance can't be used for African American men. I just think that there's some differences about their anatomy and their prostates that we've just discovered. So that's the first point. The second point is that MRI is a good tool to see that. So we, at a good imaging center, MRIs can see cancers that are big, that are in different spots in the prostate. They can see big prostate tumors that are in the posterior part as well as the anterior part. So I think that doing an MRI at this point is our best tool. The other option would be to have an extensive biopsy, which we haven't explored, and actually tested which is the best approach. And it's not that every man has that, but it's more common. It's about 1 in 3 men have a change in their grade, etc. So the idea is it's a balance of what are my likelihood of having this issue, and I think an MRI can provide some reassurance. And Dr. Carter's published a nice paper that looks at the use of MRI in all men who are considering surveillance. It's a good tool. So that would be one option, and then considerations for more extended biopsies is another option.
Standard for African American men to maybe have an MRI in conjunction with biopsy.
Well, yeah.
Standard is maybe a little too strong a word. In a program like we have at Johns Hopkins, it is standard because we want to learn how to use it.
For everybody.
For everybody. So it's standard for Caucasians and African Americans and everyone else.
But not other facilities. Okay, thank you.
Okay, I saw Dr. Kennard, and then we'll have a question here.
I think I heard Dr. Carter refer to either over surveillance or over diagnosis in your presentation. Is there a precaution to be observed in terms of how you advise prostate cancer patients over diagnosing?
So the term overdiagnosis is used by most people to indicate an outcome after screening, meaning that about 1 in 4 men in this country who get diagnosed would not otherwise have known about their cancer if they hadn't been screened in the first place. So that's overdiagnosis, and obviously it changes depending on what age you are. The older you are, the greater the risk that the cancer's been overdiagnosed, because those men don't have as long a life expectancy, whereas younger men are less likely to be overdiagnosed. So we, in the surveillance program, we don't deal so much with trying to estimate overdiagnosis rates, but what we're trying to do in our surveillance program is identify those men who we think can safely be monitored. And just to make a comment about the African American situation and Dr. Schaeffer's discoveries, what his discoveries have made me more aware of is that in an African American who's younger and is telling me they're interested in surveillance as compared to a Caucasian, I'm going to be a lot more worried about the younger African American having a cancer that I miss and less enthusiastic about monitoring them.
Yes, another question back here.
I'm 59 years old. I've just been diagnosed recently with prostate cancer, 5.5 PSA, 6 Gleason score. And your presentation started, the first one started out very hopeful that, I was low risk. But I guess that's the confusion. I mean, if the PSA is the number that you're screening, what difference would it make what a tumor is? I'm hoping I'm asking the question correctly.
Well, I guess your bottom line question is whether you're a candidate for active surveillance.
No, I'm asking the question.
Yeah.
Okay, I'm sorry.
So what happens is that if your PSA is 5.5, then your doctor would say maybe you should get a biopsy. And so you had a biopsy, and your biopsy more often samples this posterior part of the prostate, okay? And African American men get cancers in that area, and that's what your biopsy picked up. Now the question is, in your case, or any man's case like yours, is there something that wasn't sampled by the biopsy that's more significant or more worrisome? Okay? And that may be a tumor that just was randomly missed by the biopsy gun in the posterior area, or maybe it was a tumor that was not missed by the biopsy needles in an anterior part of the prostate. Okay? And one of those two possibilities could have occurred. And so the idea is, well, we know from our studies that if you are Caucasian, because 90% of our men are Caucasian in our active surveillance group, that over time it's going to be relatively safe for you to continue surveillance. The finding is that we're more likely to detect a more aggressive tumor in an African American man than compared to a Caucasian man. And the reason may be, we believe, because these tumors hide in this anterior spot. So it doesn't mean that the tumor that they picked up on the biopsy wasn't a 6. It was a 6. But what it means is that we should have heightened awareness that you may have a more aggressive cancer somewhere else in the prostate that was missed by the biopsy.
The only thing that really picks that up, you're saying, is like the MRI or something?
Well, you can either sample the prostate more with the biopsy, and as Dr. Carter said, in our active surveillance program, if you look at when are the high-grade cancers picked up, it's in the first 2 years. And the reason probably is because we're sampling the prostate more. We do more biopsy cores than normal for active surveillance, and so it's picking those up. So the idea is you could consider an MRI that may provide some guidance, or a rebiopsy or more extensive biopsy may find it too.
I'm traveling distance. I got one more question. all these medications on the market to decrease or lower your PSA count, that really doesn't do anything, especially if the PSA is only reflecting an area. So throw that kind of stuff out the window.
I would agree with you. I think the strongest evidence is the FDA very, very carefully evaluated all of the evidence, whether or not those medications lowered the risk of prostate cancer, and the answer was no, they should not be used for prevention. You already have the disease, so I don't think they should be used.
Okay, thank you for that question. I have one more question, Dr. Carter.
John Carter. We operate a prostate cancer screening and education program at Dana-Farber in Boston, and there's been a lot of, this sort of goes in two directions, but a lot of cutbacks in sort of the screening activity based on all of the information coming about these guidelines. So just as she mentioned, the pullback in these community programs. But another piece is that, we've sort of been pushing a little bit this active surveillance for men who have low-grade cancer, part of education, and I'm sensing that there's a significant amount of unreliability in our ability to sort of give this information to these guys when in the background there's always this greater risk of this, these anterior cancers. And I guess one question I'd have is, biologically, and this question came up yesterday, biologically, is the hormonal stimulation activity in the anterior portion of the prostate any different than in the posterior portion? Does anybody have any information on that?
Yes.
Does that create more aggressive cancers for some reason as the men get older?
So you made two very good points. One, I don't think that this makes me not recommend active surveillance for African American men, but I think you have to be the idea is it's a dialogue with the patient. So you have to review over the evidence that we have, maybe have heightened awareness, think about doing some additional studies to try to find these, because not every African American has it, but we need to be a little bit more keyed in that they may have it, okay? And in fact, we changed our biopsy protocol about 5 years ago in all men in our active surveillance group because Dr. Carter and Dr. Epstein made an observation that anterior cancers can hide even in Caucasians, and maybe we should sample that area. So we sample that area now in our active surveillance group as part of our standard biopsy protocol. So I think that's the first point. The second point about biologically what may be responsible for this, because it's an anatomic phenomenon, is an area that we're ramping up our research on. And I have a research lab. I operate on men with cancer, but I have a research lab too. And so we've really changed our whole direction towards this, understanding more what this is. Is it that there's a difference in the hormones in African American men versus Caucasian? Is it a difference in the distribution of the regions? Is there some effect of diet, environment? All these factors we're kind of beginning to explore now.
Good, very good. I want to say one thing, and then we're going to move on. Yesterday, we released our consensus statement on PSA testing for African American men, and after listening to the presentation today, and by the way, there's no conflict between PSA testing and active surveillance. Very frankly, you can't go on active surveillance unless you have a PSA test and you know your prostate health. But listening to the presentation today by Dr. Schaeffer, I think I can't say I'm more committed to that because I've always been committed at the 10th degree level. But I think that supports the strong statement, a strong recommendation that African Americans get a PSA test for cancer because we can put them in an active surveillance program and monitor if we so choose. But if you don't know and you have a very active, very aggressive cancer someplace hiding and you don't know about it, then we have a better understanding of why more black men present with a more advanced stage disease. So the statement on PSA testing for African American men, I think really supports, or their presentation supports that statement. I don't know whether either of you would want to comment on that, Dr. Carter or Dr. Schaeffer.
Well, no, we have spoken before, and yeah. I applaud Finn's views. The AUA, the panel was asked to create an evidence-based guideline, and when there was no evidence regarding high-risk individuals, the panel felt they could not go beyond the evidence. Now, I will tell you that there's a rationale for that, because this is not an intervention. It's very easy to come up with a guideline for overactive bladder. Those people have symptoms. It's very easy to come up with guidelines for people who are symptomatic and are having a problem. But when you're talking about intervening or doing something with people who are completely asymptomatic, the bar has to be very high. And so the Institute of Medicine helped guide the workings of this guideline panel, and because there was no evidence on high-risk individuals, whether the family history, whether they're African American, we felt it was not appropriate to address that. So we addressed average risk men. Now, I think the message may have been a little misinterpreted in the media, and that's a shame. And you know, that may in part be my fault or the AUA's fault. But again, I don't think anyone in the AUA would disagree with what Finn is doing, with one caveat. Someone alluded to these mass screening efforts where you see hundreds and hundreds of men coming to get a PSA test. Those are often promoted by institutions who have a tremendous monetary reward for doing that. And our panel felt that that was inappropriate and that it was perfectly appropriate to educate those men and then let them have a shared decision-making process with a physician about whether PSA screening was right for them. Because not every African American who hears the risk of harm is going to say, yes, I definitely want to be screened.
I'm going to end this part of this panel, and I think it's been very, very informative and very educational. And we thank both Dr. Carter and Dr.